Welcome to the Victorian and Tasmanian Primary Health Network Alliance Practice Education webinar series. This webinar is on the health of the older person. My name is Paresh. I'm a practicing GP in Canberra with a practice entirely focused on providing outreach care to older people and those with complex and chronic needs. I also work at the New South Wales Agency for Clinical Innovation and New South Wales eHealth as a consultant GP specialist advisor. I have academic affiliations at a couple of universities and am the editor-in-chief of BMJ's Integrated Healthcare Journal. I'm delighted to be joined by Gary Smith today. Welcome, Gary. May I ask you to introduce yourself?
Thanks, Paresh. I'm a practice manager of a 12-doctor general practice at the foot of the Blue Mountains, west of Sydney. I'm academic director at UNE Partnerships, also chair of QIP and director of AgPal. I'm also an AgPal co-surveyor. We also sit on the board of my local primary health network and my local health district. And for the Tasmanians on this webinar, I'm on the board of HR Plus in Tasmania. Thanks, Paresh.
Thanks, Gary. First, let's start with an acknowledgement to country. We acknowledge the Aboriginal and Torres Strait Islander peoples as the traditional owners of the lands. We wish to pay our respects to their elders, past, present, and emerging, and acknowledge the important role Aboriginal and Torres Strait Islander people continue to play within our community. This webinar has been developed by Eastern Melbourne PHN on behalf of the Victorian and Tasmanian PHN Alliance, which is a collective platform for the 7 PHNs in Victoria and Tasmania. The webinar was made possible with funding support from the Australian Government Department of Health. The Commonwealth of Australia, Eastern Melbourne PHN, and the participating Victorian and Tasmanian PHNs do not accept any legal responsibility for any injury, loss, or damage suffered as a result of the use, reliance upon, or interpretation of the information contained in this webinar. This webinar is to be used as a guide only, and practices should read and refer to the references provided along with this webinar. This webinar is on the health of the older person, and by the end of this webinar, you will have had an opportunity to consider what we mean by health of the older person and what the needs of older people are. The topic is a large one, and so we will focus on the principles of an approach to caring for older people and touching on how you can embed those principles into your workflows and care planning processes. Whether you are a GP, a nurse, a pharmacist, an allied healthcare professional, or a non-clinical member of the team, such as a receptionist, as we go through this webinar, we urge you to consider what your role is in the health of the older person. I'd like to invite Gary to give us any upfront comments on the topic of this webinar today. Thanks, Gary.
I only have one, Paresh. I hope you define the term older person because I'm really worried that I may fall into this category. But I'm looking forward to your presentation where I think you will be very clear about the parameters around the definition of the health of an older person.
Thanks, Gary. Absolutely. Throughout this webinar, we'll be talking a lot about the what, covering the concepts, the evidence, and the knowledge. As we do talk about the what, we'd like you to consider the so what. So what does this mean for you in your role, for your practice and workplace? By the end of the webinar, we would ask you to consider the now what. Having heard from us and considered your context, we hope you will have 1 or 2 ideas to test out in your practice. The now what will make the difference to your patients, and so it's an important outcome for this webinar. Whenever we start to talk about certain populations like older people, we all have some preconceived ideas which aren't always correct. The World Health Organization has listed 10 misconceptions and made attempts to debunk some myths about older people's care, which are listed on this slide. We want to emphasize a few of them. Every older person is unique, and therefore care is about individualizing for each and every person. The diversity we often see in older people is a reflection of life experiences in earlier life, and as such, social determinants of health are just as significant in this group. Health is so much more than absence from disease, and we discuss this in the next slide. Whilst only a small proportion of older people are care dependent, it is important to recognize that families and relatives alone cannot provide the care, and so we need to consider the long-term care system, and in doing so, make appropriate investments to deliver effective and efficient care. And speaking to Gary's point earlier, you'll see 70 is not yet the new 60. The arbitrary definition of an older people by age alone is perhaps not the way forward. It's really based on what their needs are. So, what do we mean by health? The World Health Organization in 1947 developed a definition which was one of a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. Interestingly, over the last few decades, this definition of health has been challenged. In particular, the word physical. Older people are more likely to have long-term conditions, and a more contemporary definition strives to focus on the ability to adapt and self-manage across the dimensions of physical, mental, and social well-being. Therefore, as healthcare providers, if we want to support our patients with a focus on an ability to adapt and self-manage, then we need to understand the factors that help determine health. The diagram on this slide is from the World Health Organization and shows that health and functional ability arise from an interplay between a person's external environment and their intrinsic capacity. The environment consists of a range of factors, including the built environment, people and the relationships, attitudes and values, health and social policies, the systems that support them, and the services that they implement. On the other hand, the intrinsic capacity consists of a combination of factors such as genetic factors and personal characteristics like sex and ethnicity, as well as social determinants. It also includes health characteristics such as biomedical risk factors, physical medical conditions, and psychological health. One really useful way of looking at health in older people is through observation of trajectories of health. These trajectories are illustrated on this slide. The blue line shows an optimal trajectory where one's experience of a high level of health right until the end of life. However, more commonly, we see trajectories such as the yellow and red line. The yellow line represents trajectories of intermittent events with variable degrees of recovery, therefore leading to a decline in health over time. Such trajectories may be seen with conditions such as heart failure or significant events such as pneumonia. The red line shows a trajectory of gradual decline until the end of life, and typically we may see this in people with dementia and frailty. If we're going to deliver better care and health for older people, we need to really understand how to measure what matters and how we can deliver services and care to achieve what matters to older people. Consider who and when you might do this. Receptionists in the waiting area, practice nurses during care planning and health assessments, or GPs during consultations. The diagram you see on this slide comes from the International Consortium for Healthcare Outcomes Measurement, ICHOM, and identifies the different aspects of health that matter to older people. We'd really encourage you to have a look at these aspects in more depth after the webinar. Notice how in what matters, overall, there's the absence of condition-specific details for example, diabetes or cholesterol levels or indicators like HbA1c. Those are, of course, important and we should absolutely measure them. However, in the care of older people, we should also measure what matters to them the most. Patient-reported outcome measures are measures that help us to do just that, measure what matters. An example is the short form 36 or SF36, a set of generic, coherent, and easily administered quality of life measures. You'll also see on this wheel other important aspects such as pain, carer burden, loneliness and isolation, polypharmacy, and place of death, just to highlight a few. In the rest of this webinar, we will consider 3 aspects which will help us to consider an approach to deliver outcomes that matter. We will talk about multimorbidity, frailty, and medicines management. So, we have seen that the needs of older people to be healthy go way beyond the medical conditions they have. Although initial definitions of multimorbidity were based on medical conditions, more recent definitions, such as that from the European General Practice Research Network, are much more broader, include biopsychosocial factors. Any biopsychosocial factor, for example, a heart condition, or social isolation, or mental health conditions, any somatic risk factor, the social network, the burden of diseases, the healthcare consumption, and the patient's coping strategies may function as modifiers of the effects of multimorbidity. Multimorbidity may modify the health outcomes and lead to an increased disability or a decreased quality of life or frailty. Gary, just wondering if you wish to make a comment on the management of medical conditions and how they relate to patients' healthcare from a practice manager's perspective.
Thanks, Paresh. An interesting question. We have all heard of the saying, rubbish in, rubbish out. This is about accurate and currency of a patient's information. It is critical to the management of patients' health that the practice team has access to patients' up-to-date clinical or, well as some demographics information to be able to provide high-quality care to their patients. So this is why processes and systems are designed and implemented in our practice to capture this information in an accurate manner. Systems like recalls and reminders and the coding of disease states of patients. Systems support high-quality patient outcomes.
Thanks, Gary, and thanks for bringing that focus on the importance of quality data to help deliver good care. If we look at a more traditional definition of multimorbidity, then the prevalence increases with age, as you can see in this slide. We can presume that a broader definition, such as what I described in the previous slide, will increase the prevalence even further. Therefore, understanding the approach to managing multimorbidity, it's really very helpful and helps us to deliver the outcomes that matter to older people. Managing multimorbidity and frailty requires us to first know who our population is. How do we identify multimorbidity? I think that's what Gary was alluding to in his previous comment. There are a number of ways we can identify multimorbidity, and these are displayed on this slide. The first two can often be undertaken by reviewing and computerized searches of practice databases, assuming the practice maintains and regularly reviews the health summaries and medications. The importance of data. Additionally, specific tools can be used which bring together multiple variables into a risk stratification process to identify populations who may benefit from a multimorbidity approach. In the next slide, we'll look at one particular tool which aims to identify frailty. Finally, multimorbidity can be identified opportunistically through the use of open questions to create conversations which helps the clinician to understand the treatment burden patients experience. Let's look at frailty assessment as an example. Frailty is a pretty common syndrome that occurs from a combination of deconditioning and an acute illness on the background of existing functional decline that's often under-recognized. In this tool from Sydney North Primary Health Network, 5 criteria are used to score the risk of frailty. Notice how only one of these criteria is related to the medical conditions. The rest look at other aspects such as fatigue, mobility, and weight loss. Health Pathways has details on the assessment of frailty. Have a look at the resource page at the end of this webinar to access your local health pathways. Managing multimorbidity really begins with a conversation on the approach to care. Discuss what the goals of care are and the quality of life may be improved by reducing the treatment burden and optimizing care. This may include many factors such as identifying gaps in care, for example, osteoporosis treatment for those at high risk of fracture following a fall, optimizing the appropriate use of medicines, and reducing the burden of follow-up by providing alternative arrangements to care. The next step is really to identify the burden of illness. One tool that is helpful categorizes burden into 3 categories or 3 groups. Healthcare tasks such as managing medications or multiple appointments and navigating the health system. Factors that exacerbate the burden of treatment and may include financial factors, personal factors, structural factors such as car parking or transport to an appointment. And the third category around consequences of health tasks that are imposed. Examples here include the lack of adherence, the emotional impact, the financial impact, the impact of professional, social, family, and leisure activities. The previous conversations can help shape what is important for patients, what their values are, what are their priorities, and hence what their goals are. The aim of managing multimorbidity is to individualize care based on the patient's personal preferences. This may include conversations about advanced care planning as well. A review of medications, which we discussed in the next slide, and all interventions is the next step in partnership with the patient and supported through a shared decision-making process. This shared decision-making process is then translated into an individual management plan, which can be shared with the patient and other providers. Once goals and priorities are known, all interventions can be assessed against those goals and priorities. Managing medications is a critical component of managing multimorbidity and outcomes for older people. There are many tasks prescribers can undertake with the practice team, and these are shown on the slide. I'd like to particularly highlight 3: medicines reconciliation, appropriate prescribing and deprescribing, and multidisciplinary communication. These 3 can help us achieve some of the other tasks, such as simplifying medication regimes. Different medications have different utilities. This diagram shows the different utility of different medications and can be really quite helpful to support discussions around deprescribing. I'd like to highlight the Tasmanian deprescribing guidance as being an important resource with this aspect. The utility ranges from those that help an acute illness to those that may modify a chronic disease trajectory, such as those lines we saw earlier in the presentation, to those which have really limited benefit, if any. As we think about the care of the older person, we need to consider what we currently do and what we need to change to deliver great older person-centered integrated care. We need to go from the column on the left to the column on the right. We know great care focuses on people and their goals, not their medical condition. It is about focusing on building their intrinsic capacity rather than being disease-focused. It is about having the older person as an active participant in their care. It is about joined up and coordinated care within and between care settings. It is about a culture where aging is considered a normal and valued part of life rather than a pathological process. Any final comments, Gary, from you?
Just the one, Paresh. I think this slide is a very good slide, putting into perspective the current state and the desired state on the management of care for the older person. The question is 67 years of age old? Maybe to a 12-year-old it is, but to a 67-year-old it may not. As you've described in your presentation, Paresh, there are other mitigating factors to the definition of the older person.
Thanks, Gary. And with, as we come to the end of this webinar, what we'd really like to do is remind you about, about the what, the so what, and the now what framework. We know every older person is different, and our role is to support and meet their needs as best as we can. Comprehensive assessment through health assessment item numbers and care planning can support us. What will you now do as a result of what you heard in this webinar? We'd really encourage you to pick one or two ideas and test them out, try them out. Maybe it's about having a conversation in your practice about using a tool like the frailty risk tool, or it's about identifying patients with polypharmacy and referring them to home medicines review. These resources signpost you to your local Health Pathways site. Health Pathways has details on the assessment of frailty, as we mentioned earlier. And here are some additional resources relevant to older people's health. This is a very big area, it's a big topic. And in this webinar, we really just touched on some high-level principles and concepts. We'd encourage you to follow up this webinar by going to these resources and exploring those concepts and principles further. This completes the webinar, and we wish you the very best in meeting the needs of older people in your communities. Any feedback or future support in this webinar should be directed to your PHN. Thank you.